As mentioned, my name is Jamani Lee, and I'm one of the data project managers for CF Data. And thank you for joining our webinar on how to access and use data from the Mother and Infant Home Visiting Program, MIHOPE and MIHOPE-Strong Start. We're joined today by Ann Warren and Kristen Fossetta of MDRC, who will be leading the presentation today. Before I turn the presentation over, I'll briefly introduce you to the Child and Family Data Archive and let you know about the structure of the webinar. The Child and Family Data Archive is supported by a contract from OPRE and housed within ICPSR in the University of Michigan. It is the place to discover, access, and analyze data on young children, their families and communities, and the programs that serve them. Users are able to access over 300 data sets with the ability to analyze selected data sets online. Users can also search and compare variables and peruse data-related publications. And of course, our user support is available to assist users in finding and obtaining data. For today's webinar, Ann and Kristen will provide you with an overview of MIHOPE and MIHOPE-Strong Start, as well as information on the study's research design and key findings, the study's restricted access files, and protections for those restricted access files. Following these sections, I will share how users can request access to the MIHOPE and MIHOPE-Strong Start data through the Child and Family Data Archive website. I'll also share how users can access MIHOPE videos. Finally, we'll close this webinar with Ann providing some concluding remarks, and I will facilitate a question and answer session. I'm now going to pass the presentation over to Kristen so that they can share information on these data.
Thank you, Jamani. We'll start with an overview of MIHOPE and MIHOPE-Strong Start. Just waiting to get control of the slides here. Okay, so in 2010, Congress authorized the Maternal, Infant, and Early Childhood Home Visiting Program, the MIHOPE program, and also appropriated funding for fiscal years 2010 through 2014. Subsequently enacted laws extended funding for the program through fiscal year 22. The initiation of the MIHOPE program began a major expansion of evidence-based home visiting programs for families living in communities that states identified as at risk. The authorizing legislation required an evaluation of the program, which became MIHOPE. MIHOPE is sponsored by the Office of Planning, Research, and Evaluation of the Administration for Children and Families in collaboration with the Maternal and Child Health Bureau of the Health Resources and Services Administration, both in the U.S. Department of Health and Human Services, HHS. 2 years later, in 2012, MIHOPE-Strong Start was launched. MIHOPE-Strong Start was a large-scale evaluation that rigorously tested the effectiveness of evidence-based home visiting in improving birth as well as health outcomes during pregnancy and in the year after birth. MIHOPE-Strong Start was sponsored by the Administration for Children and Families in collaboration with the Health Resources and Services Administration and the Center for Medicare and Medicaid Innovation of the Centers for Medicare and Medicaid Services. MDRC conducted both MIHOPE and MIHOPE-Strong Start for the federal government in partnership with James Bell Associates, Johns Hopkins University, and Mathematica Policy Research. The University of Georgia and Columbia University also collaborated on MIHOPE, and New York University collaborated on MIHOPE-Strong Start. These two studies are the first large national randomized evaluations designed to test whether and how evidence-based early childhood home visiting improves outcomes for families and young children with low incomes across multiple home visiting models. We're here today because for large projects sponsored by HHS, data archiving is encouraged to make these data available to other interested researchers for secondary use. Archiving analysis files lends transparency to a study and ensures that the time, effort, and resources spent to collect the data can help inform other research as well as program and policy agendas for years in the future. What is home visiting? I imagine many of you joining us today are already familiar, but I'll do a brief intro for those who are not. Home visiting provides individually tailored support, resources, and information to expectant parents and families with young children. Many early childhood home visiting programs aim to support the healthy development of infants and toddlers and work with families with low incomes to help ensure their well-being. Generally speaking, home visiting consists of 3 types of activities. First, assessing family needs. To identify family strengths, needs, concerns, and interests, home visitors gather information from families through formal screening and assessment and through informal means that include reading cues provided by family members. Second, educating and supporting parents. Having identified family needs, home visitors devote most of their time to providing education and support to families. And third, referral and coordination. For some family needs, home visitors may think the family will benefit from receiving more specialized services available in their community. This aspect of home visiting highlights the place of home visiting as one component in a comprehensive system of care for early childhood. The legislation that authorized the MIECHV program required awardees to devote the majority of MIECHV funding to home visiting models designated as evidence-based by HHS. To determine which home visiting models would be defined as evidence-based, HHS commissioned the Home Visiting Evidence of Effectiveness, HOME-V review. MIHOPE and MIHOPE-Strong Start evaluated the effectiveness of selected models that the HOME-V review determined to be evidence-based. Now let's talk more about MIHOPE and MIHOPE-Strong Start. As shown in this slide, the 2 studies have similarities as well as differences. In the models included, targeted sample, outcome domains of interest, and families included. While MIHOPE includes the 4 evidence-based models that 10 or more states chose in their fiscal year 2010 plans for MIECHV funding, Early Head Start Home-Based Option, Healthy Families America, Nurse Family Partnership, and Parents as Teachers, MIHOPE-Strong Start includes the 2 models, Healthy Families America and Nurse Family Partnership, for which there is some prior evidence of home visiting having positive impacts on birth outcomes. In terms of sample, MIHOPE included pregnant women and women with children under 6 months of age at the time of study enrollment, while MIHOPE-Strong Start included only women less than 32 weeks into their pregnancy. MIHOPE's outcome domains of interest were broader as well, including child development, parenting, economic self-sufficiency, child maltreatment, and intimate partner violence, measured through the time the focal child was 15 months of age, while MIHOPE-Strong Start focused more on prenatal health, birth outcomes, maternal and child health, and healthcare use, measured through the first 12 months of age. MIHOPE included local home visiting programs from 12 states, while MIHOPE-Strong Start included those 12 states plus 5 others. MIHOPE included 4,229 families, while MIHOPE-Strong Start included 2,900 families. It should be noted that about 1,800 of the families included in the 2,900 for MIHOPE-Strong Start were recruited for MIHOPE, but included in the MIHOPE-Strong Start research because they also met MIHOPE-Strong Start's eligibility criteria. The initial MIHOPE impact analyses examined outcomes when the focal child was 15 months old, whereas MIHOPE-Strong Start used a 12-month follow-up period. Additionally, families in MIHOPE were surveyed when their children were 2.5 and 3.5 years old, and data are being collected when children in MIHOPE are of kindergarten age. Now we'll talk about the design of the 2 studies, their key research questions, and key findings. MIHOPE and MIHOPE-Strong Start used a random assignment research design to assess the effectiveness of home visiting services. So families recruited into the 2 studies were randomly assigned either to an evidence-based home visiting program or to a control group who is given information on other services available in the community. Random assignment was intended to ensure that the 2 groups were similar in all respects when they entered the studies, except that one had immediate access to evidence-based home visiting. Following best practices in a random assignment study, the effects of being assigned to receive evidence-based home visiting have been estimated by comparing outcomes for the entire programming control groups. In addition to analyzing the impacts of home visiting programs, both MIHOPE and MIHOPE-Strong Start collected extensive information about home visiting implementation to describe the family served, the policies and supports in place for home visitors to provide services, the quantity and content of the actual services provided to families, and the ways those services varied. And I'll note that an advisory committee to the Health and Human Services Secretary reviewed plans for MIHOPE at various stages, and the final design and analysis reflect discussions with that committee. The following key questions were asked in the MIHOPE and MIHOPE-Strong Start implementation research. First, what services did families receive in home visiting programs? And how are characteristics of families, home visitors, local programs, and other home visiting stakeholders and communities associated with differences in the services that families received? With the rich and varied information collected in MIHOPE, the following key questions were asked in the MIHOPE impact evaluation. 1, what are the effects of home visiting programs across the range of outcomes specified in the MIECHV authorizing legislation? 2, are the effects of home visiting larger among some types of families than others? And 3, how do the effects of home visiting programs vary with the features of local programs and the services families received? With a focus on prenatal health and birth outcomes, MIHOPE-Strong Start asked the following key questions in its impact evaluation. 1, what effects did home visiting programs have on improving prenatal health, reducing low birth weight and preterm birth, and altering infant healthcare use? 2, how did the effects for families vary with family risk factors and across local programs? Give you just a flavor of the results from MIHOPE and MIHOPE-Strong Start. A key implementation research finding was that the home visiting programs in the studies were generally well implemented with appropriate support in place to help home visitors administer the intended services. This support included training for home visitors, supervision, structured parenting curricula, consultants to address specific family needs, and protocols for risk screening and referrals. However, the studies identified several ways that this support could be strengthened. In terms of impact findings, MIHOPE found positive effects across multiple outcome areas through the time children were about 15 months old. In contrast, MIHOPE-Strong Start found that the 2 evidence-based models that were examined had little effect on birth outcomes and prenatal behaviors. The findings from both studies are broadly consistent with results from previous studies of the evidence-based models of home visiting. For more information on the findings from MIHOPE and MIHOPE-Strong Start, you can refer to several key reports. An overview of findings is presented in a brief summarizing results from MIHOPE and MIHOPE-Strong Start's implementation research and impact studies. Full results from the MIHOPE implementation research are presented in the implementation research report, which was released in 2018. 15-month impact findings from MIHOPE are presented in an impact report published in 2019. A report to Congress with early findings from MIHOPE was published in 2015. And MIHOPE-Strong Start's final report presents implementation and impact findings and was released in 2019. All the MIHOPE and MIHOPE-Strong Start reports, including some earlier reports not shown on this slide, are available on OPRE's websites for MIHOPE and MIHOPE-Strong Start, which are shown on the slides here. Now that we've covered some background on the 2 studies, we'll move on to today's main event, the archived data. The MIHOPE and MIHOPE-Strong Start archived data are available as restricted access files. This means that the data files are not publicly available. And as Jumani said, we'll discuss accessing the data later in the presentation. MIHOPE and MIHOPE-Strong Start have separate restricted access files. For MIHOPE, there are a total of 13 quantitative data files, plus 2 more cost files that will be released in the future. For MIHOPE-Strong Start, there are 7 quantitative data files. Additionally, for MIHOPE, families were video recorded at a few different points in time. These videos are also archived at ICPSR, but we'll discuss later how to access them. The application and access process is separate from the quantitative data, and the videos cannot be linked with any other data included in the MIHOPE restricted access files. So access to the data itself is limited. Information about each data set is publicly available. A set of documents lives on the Child and Family Data Archive webpage for each study's data, which include a code book listing all the variables included in each data set and basic descriptive statistics, a data user's guide for each of the 13 MIHOPE files and each of the 7 MIHOPE-Strong Start files. The user's guides provide detailed information on the data included in each file and how they were used to conduct analyses. The sections included in these documents cover many aspects of the file structure, including a description of each data source, a description of the sample, response rates, variable and label naming conventions, variables deleted from the file, missing value codes, data limitations, masking, other data decisions, information on merging the data files, and a description of how to replicate the impact analyses. All the instruments used to collect the data are included in each data set's documentation as well. The publicly available documentation files are extensive and are definitely worth looking at before applying to access the restricted access files. They'll give you a sense of which data are available, sample sizes, how questions were asked, and so on. And finally, I'll just mention that in addition to the documentation and codebook for each data set, the publicly available MIHOPE documentation files also include some model-specific findings that were not part of the original MIHOPE 15-month impact report. Although MIHOPE published estimated effects by model for each of its confirmatory outcomes at 15 months, given the availability of model-specific data in the MIHOPE RAF and to provide context for RAF users, the documentation includes model-specific results for the study's exploratory outcomes and additional information on the statistical significance of estimated effects by model for the confirmatory outcomes. So now Anne will tell us more about the archived data.
Thank you, Kristen. Jumped ahead too quickly. So far, we've been discussing MIHOPE and MIHOPE-Strong Start together, but for the restricted access files, we will talk about MIHOPE first and then MIHOPE-Strong Start after that. So for now, just thinking about MIHOPE, MIHOPE collected vast and varied data. For the MIHOPE restricted access files, I think it's easier to think about the data as being at the family level, at the staff level or home visitor or supervisor level, or at the local program level. So we'll talk about each of those data sources now. For MIHOPE, data on families were collected from multiple sources and at multiple points in time. We have archived data through the time the focal child was 15 months of age at this point. Families were surveyed at baseline or shortly after study intake and when the focal child was 15 months of age. Additionally, in-person assessments were done using the infant toddler home observation measurement of the environment, or IT home, at baseline and 15 months, which is also when an in-home child assessment was conducted. In between these 2 points in time, mother-home visitor interactions were video recorded for a sub-study of families approximately 8 weeks after the family's first home visit, and then 8 months after the family's first home visit. Other data come from a variety of sources, including American Community Survey data, home visiting service delivery data, and state administrative data from all 12 states on Medicaid or CHIP enrollment and claims, as well as Child Protective Services data from all 12 states as well. Most of these data sources were collected for families in the program and control groups, but of course, data about home visiting services provided to families are only relevant to and available for families in the program group. For families, the family baseline and family 15-month survey files contain all the raw variables from those surveys, with the exception of copyrighted scale items. I'd like to note that the analysis measures created from the scales are available in the family analysis data files that are archived. The family baseline survey and study intake data include information about child and maternal health, maternal demographics, household composition, and father involvement, income and service receipt, maternal behaviors and partner status, and home visiting. The family 15-month follow-up survey data include information about child health and development, parenting, parent health and well-being, health insurance, household, family self-sufficiency, mental health and substance use, intimate partner violence, crime, and social services. These files can be useful to researchers who would like to create measures that weren't analyzed by the MIHOPE study team and included in the family analysis data file, which we'll discuss shortly. Families were directly assessed, and direct assessment data were collected through baseline infant toddler home observations, which were done for all families when field staff were in the family's homes obtaining study consent at study entry. Additionally, direct assessments were done with families when the child was 15 months of age. The information from these assessments include the 3 bag and cleanup tasks, which were also video recorded and coded. These 3 bag and cleanup tasks were semi-structured parent-child play interactions, which were observed and video recorded during the 15-month assessment. We also have the preschool languages scale, the infant toddler home, child height and weight measurements, as well as mother weight measurement. The family analysis file in the restricted data is a great place to start for family information. It includes all family level analysis measures used in the final MIHOPE implementation research and 15-month impact reports. The MIHOPE family analysis file also brings together various family data sources that we have discussed so far. Specifically, the family analysis file includes study information, such as the research group to which the family was assigned, either program or control, the model of home visiting program through which the family enrolled in the study, and a random site ID. Family baseline characteristics are described with data from the family baseline survey, including socio-demographic information, measures of maternal health and economic self-sufficiency, as well as others. In-home assessments done at baseline with the infant toddler home include measures of the mother's verbal skills, quality of the home interior, and parental warmth. Also, the study team geocoded mothers' residential addresses reported at baseline to census tracts in order to link these addresses to community characteristics from the American Community Survey's 2014 5-year estimates, including measures of a census tract's average unemployment rate, poverty rate, and racial ethnic breakdown of residents. Family 15-month follow-up outcomes were collected from surveys conducted with families covering topics such as maternal depression, education and training received, and parental distress. Additionally, state administrative data shed light on child's Medicaid paid emergency department visits, well child visits, and non-birth hospitalizations. Similarly, state child maltreatment data provide information on substantiated abuse and neglect reports and whether there were any out-of-home placements. For staff data and local program data, Home visitor and supervisor data were collected from supervisor and home visitor surveys, which were conducted at baseline or around the time the local program started enrolling families in the study and 12 months later. Service delivery data about home visiting services provided to families are included. Training logs, which were completed monthly by home visitors and their supervisors, are included, as well as supervision logs completed weekly by supervisors. For local programs, data were collected from program manager surveys, which were completed at baseline and 12 months. Site log data, which include information collected during the site recruitment process. American Community Survey data for families at the local program level, and information on local program policies alignment with those reported by the national model developer of the relevant evidence-based model. The period of time covered by the staff and local program data is slightly different than that for the family data. The staff and survey data cover the time from when the local site started enrolling families in the study through 12 months later. The family data, however, generally cover the period of time from when the family was enrolled in the study through the child's 15th month of age. Note that there are a few data sources from MIHOPE that were not archived, specifically administrative data on employment and earnings, and MIHOPE State Program Administrator Survey data. For home visitor and survey data, we have specifically archived home visitor and survey responses to surveys at baseline and 12 months later. These surveys included questions about demographic and psychosocial characteristics, as well as the staff members' perceptions, attitudes, and beliefs regarding work. Both home visitors and supervisors provided data on the dosage, content, and modality of training they received on a monthly basis. These training logs were expected to be completed each month, regardless of whether a training actually occurred. Supervisors also provided data on the dosage, topics, and methods of supervision provided to individual home visitors on a weekly basis. These supervision logs were expected to be completed each week, again, regardless of whether individual supervision actually occurred. And for the home visiting service delivery data, for all families in the program group, home visitors provided data on services delivered to individual families on a weekly basis. These family service logs were expected to be completed each week, regardless of whether a home visit occurred during that week. The family service logs provide information on dosage, including the frequency, type, and duration of home visitor contacts with the family, home visitor continuity, visit content, including topics discussed, referrals provided, and levels of family responsiveness. These data are available for families in the program group only. From local programs, data were collected from program manager surveys, which were completed at baseline and again at 12 months. Program managers at each of the 88 local programs in MIHOPE provided information on characteristics of local programs, such as service plan elements, policies and protocols, presence and types of implementation system supports, and networks of referral agencies. Site log data, which include information collected during the site recruitment process, such as how long the site has been operating the home visiting model, were also collected. And American Community Survey data for families at the local program level, or aggregated for families associated with the local program, are included. The measure in MIHOPE's restricted access file is related to the Neighborhood Community Socioeconomic Disadvantage Index, which is a composite of 4 measures based on work by Turney and Harknett from 2010. The 4 measures are the percentage of individuals 25 years of age and older without a high school degree, the percentage of individuals unemployed, the percentage of families living in poverty, and the percentage of families receiving public assistance. Finally, we also have data on local program policies alignments with those reported by the national model developer of the relevant model for the program. As mentioned earlier, families were video recorded at in-home assessments when the child, after 8 weeks after the first home visit and 8 months after the first home visit. The videos were coded to rate parental supportiveness, sensitivity, positive regard, stimulation of cognitive development, intrusiveness, negative regard, and detachment. The child subscales include engagement of parent, sustained attention with objects, and negativity toward parent. These codes are available in the archived quantitative data from MIHOPE. The videos themselves are available, but may only be viewed in the physical data archive in Ann Arbor, Michigan, and those videos are not linkable to any other data included in the quantitative files. So I just talked about a lot of data that are archived from MIHOPE, a few tips and things to note when using the MIHOPE restricted access files. The family analysis file includes family baseline and outcome measures used in the MIHOPE implementation research report, the 15-month impact report, and additional variables from administrative data sources. This is a great place to start if you're interested in the families and the family data in MIHOPE. Other family data files can be used to create additional variables of interest, such as the family baseline survey data or the family 15-month survey data. These other data files include the raw variables that were used to create the analysis variables in the family analysis file. A few families that were included in the implementation and impact analyses for MIHOPE are not included in the restricted access file data. So please be aware of this and don't worry if you're comparing sample sizes in the MIHOPE restricted access files to those from the published reports, as they are slightly different. All of these details and many more are included in the restricted access file documentation memos that are publicly available from ICPSR's website. Okay, now we'll switch gears and talk about MIHOPE-Strong Start. I will keep this discussion a bit briefer, but many of the MIHOPE-Strong Start data sources overlap with those from MIHOPE, so this will sound familiar. One difference between MIHOPE and MIHOPE-Strong Start is that all the follow-up data used in MIHOPE-Strong Start were derived from state Medicaid CHIP and administrative state vital records data. So specifically birth and fetal death records data from the 17 states with local home visiting programs in MIHOPE and MIHOPE-Strong Start. And as a reminder, one key difference between MIHOPE and MIHOPE-Strong Start is that MIHOPE-Strong Start included only women who enrolled in the study when they were pregnant, no more than 32 weeks into their pregnancy. And as a result, only Healthy Families America and Nurse Family Partnership home visiting models were included in MIHOPE-Strong Start. The family baseline survey data from MIHOPE-Strong Start includes information about maternal health, maternal demographics, household composition, income, maternal behavior, partner status, and service receipt. Data from MIHOPE baseline survey respondents were mapped to the MIHOPE-Strong Start survey data, since some sample members included in MIHOPE-Strong Start were enrolled through a local program recruiting families for MIHOPE. More details about this mapping is available in the documentation memos associated with these files. For MIHOPE-Strong Start, the study team also geocoded mothers' residential addresses reported at baseline to census tracts in order to link the addresses to community characteristics from the American Community Survey's 5-year estimates, including measures of a census tract's average education level, neighborhood density, poverty rate, and uninsurance rate. Outcome data, specifically about birth outcomes, maternal and child healthcare use and health, were derived exclusively from administrative data. These data sources, again, were birth records and fetal death records and Medicaid and CHIP healthcare use information through the child's 12th month of age. Key outcomes from these data sources include whether a child was born with low birth weight or was preterm, and breastfeeding initiation status. Also, information on Medicaid paid healthcare use for children, such as emergency department use, well child visits received, and hospitalizations, and healthcare use for mothers, such as whether she had a postpartum visit, is included. For MIHOPE-Strong Start, we also have home visitor data. Home visitors responded to surveys approximately 6 months after the local program started enrolling families. The home visitor surveys included questions about demographic and work experience, as well as home visitors' perceptions, attitudes, and beliefs regarding their work. Like the MIHOPE-Strong Start family baseline survey data, data for MIHOPE home visitor survey respondents were mapped to the MIHOPE-Strong Start survey data. The family service logs are the primary source of service delivery information for families participating in MIHOPE who also met the eligibility criteria for MIHOPE-Strong Start. The family service logs were completed weekly by home visitors and provide information on dosage, including the frequency, type, and duration of contacts with the family, home visit content, including topics discussed and referrals provided, and levels of family responsiveness. Family service logs were completed between November 2012 and July 2016. Evidence-based model, state, and local program level management information system data, or MIS, are the primary source of information about service delivery for families in MIHOPE-Strong Start. MIHOPE-Strong Start collected MIS data starting in mid-June 2014 through the end of December in 2016. The study team worked with each MIS contact to identify and collect measures that could be pooled with the information from family service logs. Of course, these data are available and were collected for families in the program group only. For local programs, data were collected from program manager surveys, which were completed 6 months after the local program started enrolling families. Program managers at each of the local programs provided information on characteristics of the local program, such as service plan elements, policies and protocols, presence and types of implementation system supports, and networks of referral agencies. Site log data were also collected, which include information about the site recruitment process. American Community Service data for families at the local program level are also included, and the measure included in MIHOPE-Strong Start restricted access data is the percentage of families living in poverty. Finally, data on local program policies alignments with those reported by the model developer of the relevant model on maximum home visitor caseload and supervisor caseload are included. So again, a few tips and items to note when using the MIHOPE-Strong Start restricted access files. Since mothers were enrolled in pregnancy for MIHOPE-Strong Start, some women gave birth to twins.
Anne?
Yes.
I'm sorry to interrupt. It looks like you went ahead a couple of extra slides.
Okay, thank you. I think
Yes, no problem. It happens to everybody.
went ahead a few slides. Thank you. Oh, I'm so sorry. I'm going in the wrong direction. Jumani,
okay.
maybe you can take the control of the slides back. I'm not seeing the arrows right now. We're on this slide for tips for using MIHOPE-Strong Start archive data. There we go. Thank you. Sorry about that. So for MIHOPE-Strong Start, just a few final items and tips when using the data. As I was saying, women enrolled in MIHOPE-Strong Start, and we can't control this, but some women gave birth to twins. There were 49 twins in the sample out of 2,900 mothers. So impact analyses for children in MIHOPE-Strong Start were clustered by a family ID. So you'll see a family ID number in the MIHOPE-Strong Start data. In MIHOPE, only one child was included in the study sample from each family. But again, that was not the case for MIHOPE-Strong Start. Another adjustment that we made for MIHOPE-Strong Start was to the regression model for both mothers and children. We had to account for a different random assignment ratio that was used for families enrolled in MIHOPE versus MIHOPE-Strong Start. MIHOPE-Strong Start used a 60-40 random assignment ratio with more families randomly assigned to the program group than the control, whereas MIHOPE used a 50-50 ratio. Therefore, for MIHOPE-Strong Start, the program group members were underweighted in the models, whereas the control group members were overweighted in order to return to a 50-50 random assignment ratio. As I mentioned with respect to the survey data in the last couple of slides, some local programs enrolled families in MIHOPE, but these families were also eligible for MIHOPE-Strong Start and included in the MIHOPE-Strong Start analyses. For this reason, some families and staff responded to surveys that were from MIHOPE, and information about exactly how the questions in MIHOPE were related to those asked in MIHOPE-Strong Start are available in the documentation regarding that mapping. Let's see if we can go to the next slide, Giovanni. Now I'll turn to a few details about specific protections in place for the MIHOPE and MIHOPE-Strong Start restricted access files. Most importantly, the data were masked to protect confidentiality. Verbatim responses and calendar date variables were dropped from the MIHOPE and MIHOPE-Strong Start restricted access data files. Variables that were potentially identifiable were masked, but no masked variable changed significantly from its original version. Key analyses were rerun to verify that results with masked data were similar to those in the published findings. These replicated results are available in the MIHOPE Family Analysis Documentation Memo and the MIHOPE-Strong Start Overall Documentation Memo. Next slide, please. Regarding requirements for accessing the restricted access files, researchers must protect all sample members' information from deductive disclosure risk. Researchers must not combine the restricted access data with any external data sources. And they must not combine data from MIHOPE and MIHOPE-Strong Start restricted access data files together. The videos can only be viewed in the Physical Data Archive Enclave in Ann Arbor, Michigan. The Physical Data Enclave does not allow researchers to take information in or out of the space, which would allow them to link the videos with information from other archive data sources. For MIHOPE, a few other measures have been taken to protect participant confidentiality. First, researchers must have a principal investigator with a PhD or other terminal degree for their work, and these researchers must meet other requirements as well. Additionally, staff associated with programs participating in MIHOPE, which includes current or former home visitors, program managers, supervisors, national program staff, state agency staff, and other MIHOPE program staff must complete a supplemental agreement committing not to interact their local program data with restricted access files, videos, or quantitative data. These staff associated with programs participating in MIHOPE must indicate whether they have had personal familiarity with a study participant, that is a mother, child, home visitor, or supervisor in the study. If staff associated with programs participating in MIHOPE do have personal familiarity with study participants, then they may not directly access the restricted access files or videos, but they may work with another researcher who does not have personal familiarity and who can share aggregated results. Again, these limits are in place in order to avoid the risk of re-identifying study participants. For MIHOPE-Strong Start, very similar restrictions are in place. The only difference here is that MIHOPE-Strong Start included some different programs and study participants than MIHOPE. So for the consideration regarding the staff that are associated with the participating program in MIHOPE-Strong Start, they're slightly different than those that we discussed for MIHOPE.
All right, thank you, Anne. I am now going to discuss how you can access the MIHOPE and MIHOPE-Strong Start data on the Child and Family Data Archive website. So to access these data, you go to our website at childandfamilydataarchive.org. And to find these studies, just enter the study title or acronym into the search bar that's highlighted here, and then click on the study title as it comes up in the search results. The link in the search results will take you directly to our homepage. Here's a screenshot of the MIHOPE homepage. This homepage is where you will find very important information, such as a summary about the study and information on the study's methodology, sampling, and more. The study's homepage is also where users can search and compare variables and view publications that use the data. And while users may preview and download the public documentation located on the Data and Documentation tab, a restricted data application is required for users to gain access to the restricted data in all of the study's documentation. To begin your application, click on the Access Restricted Data button highlighted here, and then follow the instructions and complete the sections that I will show you on the next slide. So this is the application for accessing the restricted data. So the application requires several pieces of information, including a description of the intended research project, a data security plan, an IRB letter, and a signed data use agreement. Archive staff are available to assist you with your application and to answer any questions that you may have. Just send an email to cfdata-help@umich.edu with the application request number, and I'll show that email at the end of the presentation as well. Note that this application is required for both the MIHOPE and MIHOPE-Strong Start data, but there is a different process if you're interested in the MIHOPE videos. So I'm now going to share how you can access these MIHOPE videos. Due to the restriction level, the MIHOPE videos are stored at ICPSR's physical data enclave and can only be accessed on site in Ann Arbor, Michigan. To request access to the physical data enclave, you must submit an application for use of the physical data enclave. As with the MIHOPE quantitative data, you may start your application, or you may start your access request by visiting the MIHOPE homepage on our website, and then you start your application by clicking on the Access Restricted Data button. The physical data enclave, otherwise known as the PDE application, requires the completed and signed restricted data use agreement, including attachment G, shown here, listing which videos you want access to, and planned physical data enclave access request dates and description of your research project and intended analysis. Users must receive permission to access the videos before traveling to Ann Arbor. And again, please email us at cfdata-help@umich.edu if you have any questions or need assistance. When using the physical enclave, several guidelines are in effect to ensure the security of these highly secure data. No laptops or any electronic equipment are allowed in the enclave, and an ICPSR staff member will be present during your visit to the physical data enclave. And any output must be vetted by the ICPSR staff. We've also included additional guidelines to ensure visitor safety during COVID. For questions or assistance with your physical data enclave application, please email us. And now I'll be turning it over to Anne for some concluding remarks.
Thanks, Jumani. So just to conclude, we would like to offer a heartfelt thank you to our study participants. MIHOPE and MIHOPE-Strong Start have been able to develop a greater understanding of the 4 evidence-based home visiting models thanks to the local programs that participated in the studies. We are deeply grateful for their participation as well as for that of the families. We're also thankful for the contributions made by MDRC's MIHOPE partners, specifically James Bell Associates, Johns Hopkins University, Mathematica, the University of Georgia, and Columbia University. And of course, we are very grateful to our sponsors of the study, the Administration for Children and Families and the Health Resources and Services Administration within the U.S. Department of Health and Human Services. For MIHOPE-Strong Start, we also thank MDRC's project partners, specifically James Bell Associates, Johns Hopkins University, Mathematica, and New York University. We're grateful as well to the Administration for Children and Families, the Centers for Medicare and Medicaid Services, and the Health Resources and Services Administration within the U.S. Department of Health and Human Services.
All right, so now we're happy to take some questions. And if you need to clarify any of your questions, just please raise your hand in the chat so that we can unmute you. So the first question we have is, do you have information on services that the control group might have received from other community programs?
Kristen, do you want to take this one?
Sure. So we did ask a few questions in the MIHOPE 15-month follow-up survey about services and supports that families had received. And so for control group members who responded to the 15-month survey, we have a little bit of information on other services. And so you'll find that in the, I think what's data set 3, which is the 15-month caregiver interview data. And I can put that, I can type that also so that you have that information. I hope that helps, Laura.
Great. So our next question is, what data on economic self-sufficiency is available given employment data was not achieved? Sorry, not archived.
So I can start off that one, and Kristen, if you have additional information to add, please do. So we refer to family economic self-sufficiency in terms of covering like public benefit receipts, supports that may have been received, as well as education and training and employment supports and services. So it kind of covers a broad range of aspects related to a family's income and not just those for earnings.
Okay.
And I'll just add, sorry, Johnny. So the data that wasn't archived was the employment data that we accessed through the National Directory of New Hires. And so that data is available to us in a more restrictive way also. And so we don't have full access to it either. So we weren't able to archive it. But we did ask some questions about, the areas that Anne mentioned on the MIHOPE 15-month follow-up survey again. And so you will find that information in, I think, both the data set 3, that caregiver interview 15-month data, as well as the family analysis file, because we did have some outcomes that we looked at in our 15-month follow-up related to economic self-sufficiency. So there is still information available, just not that specific information that we accessed through the National Director of New Hires.
Okay, great. So the next question is, sorry if I missed it, but when you coded home visits with HOVRS, did you use a subset of items or the entire measure? Also, I don't remember if HOVRS including negatively worded items like detachment. Thank you.
And do you want me to speak to that also? Or would you
Yeah,
like
that'd
to?
be great. Thanks.
So this is not a part of the study that I was directly involved with. And so I think if you just look at the documentation for the mother home visitor interaction video coding data, you'll see some details about what was coded there. And that is on the website data set 13. So that documentation should give you all of that detail about that scale. And please follow up if you have additional questions.
Okay, great. And the next question is from, does the no birth hospitalization data include diagnoses and length of stay? And this individual also had raised their hands. So he wanted to clarify his question. Okay, I just gave him permission to speak. Okay, he should be able to speak.
Yeah, thanks.
Okay.
So I actually had several several questions. The first one was whether the hospitalization data include diagnoses and lengths of stay. The non-birth hospitalization data.
So for MIHOPE, we have information that are archived about the nature of the hospitalization, being injuries of the healthcare encounter, being injuries or ingestions. And I do not think we archived the length of stay, but I
Okay.
would double check on that.
Yep, thanks. And I just wanted to be clear, is this, so for hospitalizations, you're able to separate hospitalizations from emergency department encounters. Is that correct?
I think it's different from MIHOPE and MIHOPE-Strong Start. So I would have to kind of go back to the documentation and just double check. I don't want to give you the wrong information.
Okay, well, thanks. I think it's it'll be useful to know if it's either the existing data are specified in that way, or whether it's possible to separate out an emergency department encounter from a hospitalization. And again, the reasons, as you said, would be very helpful. So that was my first kind of, yeah, go ahead. And
to confirm that for MIHOPE, we do have any healthcare encounter for injuries or ingestions in the data, not necessarily what type of encounter. That particular
how difficult is it? You know, let me ask, if I may. I understand that that's you know, there from a clinical perspective, that's those types of encounters are enormously different. So, you know, I'm hoping that in the future there's a possibility of sorting that out. But how about Strong Start?
So I have to get back to you on the healthcare measures exactly in the data for Strong Start.
Okay, well, that those again are really, yeah, from my perspective, they're really important distinctions. Then I wanted to ask about, do you have data from either MIHOPE or MIHOPE-Strong Start on the timing to subsequent pregnancies following the index birth?
I guess just following up, just going back to your other question, I did quickly check, and MIHOPE-Strong Start does not have any information archived on injuries or ingestions. So I'm not sure if that will be of interest to you.
Well, you know, and
But we certainly take your comment, and we'll definitely consider that for future data that we are working on.
thank you very much.
Thank you. And your other question was about the subsequent births.
Yes.
Kristen, I think this is more of your domain. I think MIHOPE did look at subsequent births, but MIHOPE-Strong Start did not.
Yeah, we have some information on that from our MIHOPE 15-month follow-up survey. And again, the documentation has all of the details on exactly how we asked that question and what information is available.
Okay, thanks.
Yeah.
Okay, great. Our next question is on the what are the data security requirements, for example, like the type of computer and office space. So for those specific requirements, we have those listed in attachment C of our restricted data use agreement. So when filling out the application, whether it's for the quantitative data or the physical, so for the quantitative data, if you reference the attachment C, that lists all that information. Our next question is for how long does it take to process applications, and how quickly can we receive the restricted access files? And for that question, generally what happens is after an application is submitted, is reviewed by ICPSR staff. The amount of time it takes to review an application depends on whether and how many changes are required for approval. ICPSR staff work with the requester until all the information is provided and the request can be approved, and that generally takes about 2 to 4 weeks from the time that the application is submitted. The next question is, and I guess one thing is for the physical data enclave, the process just needs to allow the researcher, the process just needs to allow for the researcher to schedule, they just need to schedule their time to come to Ann Arbor, their travel time that needs to be taken into account. The next question is, do you have data on timing to subsequent pregnancies or subsequent births?
That was a question that we answered.
Oh, sorry. Yeah. Okay. And then we had some questions in the chat as well. Let's see here. So one of the questions was, I had some thoughts on research questions I could ask using MIHOPE data, research questions for my dissertation. Is there someone I can chat with to vet whether these would be viable research questions?
So Jumani, I think this might be a question for you, and it sounds like ICPSR is available during the application process to field questions from applicants for the data.
Yeah, I would say to email us at cfdata-help@umich.edu, and we can provide you any user support related to accessing the data, and as well as when we look at your application, we look at the research questions that you're providing as well.
Imani, would you like me to read one of the other questions that I was referring to in the chat?
Sure.
Okay, since I have it right there on my screen and I know which one because it's hard to scroll up and down through it. So there's one that says, you mentioned service logs and dosage data for program families only. We can link to that data to the home visitor across the entire duration of their enrollment in the study, correct? Is there data there on parent engagement during the visit itself or parent home visitor relationship? Who would like to take that question?
So I can just kind of broadly speak to it, and maybe if Kristen has more information to add, please do. In general, the service delivery data documentation memos have very detailed information about what was collected. There's an identifier for the home visitor that allows for one to see the for each family, like how many different home visitors a family saw and for how long, and vice versa with the home visitors. Additionally, I believe engagement is, I'm not sure about parent engagement, whether it's related to the actual home visit itself or more broadly speaking to home visits across the family's time in the study. That's a good question, but Kristen, if you know, maybe you can chime in. Otherwise, I think we'd have to look into it and get back to the person who asked the question.
So I guess I'd say we have some information about the content and the topics that were discussed during visits, but we don't have information, I think, across all of the visits that we have in our service delivery logs about more of the qualitative measures of parent engagement and their sort of more qualitative relationship with the home visitor. But we do have those coded coded data for the videos that we had of the mother and home visitor interacting. And so that might be interesting to you if you're interested in more of that the qualitative side of engagement. So please follow up if that didn't answer your question.
Okay, we have another question here. That was helpful, but do you have a video of each home visitor patient pair, even if it's just one per home visitor parent? Sorry, parent pair, even if it's just one per home visitor parent.
Right. We don't have a video for all of the families included in the study, just for a small subset. As you can imagine, those took some effort to acquire. So yeah, it is just for a limited subset of families that we have those videos.
We have another question that came in. Should I read it now? Okay,
Sure.
I will. Can you please say again exactly which information is available to the public through ICPSR's website and what researchers have to do to apply for access?
Okay, yeah, so the MIHOPE, both the MIHOPE and MIHOPE-Strong Start quantitative data are both restricted, and so you need to apply for access. And the video data is also restricted, but it's more restricted than the quantitative data, so you actually have to apply to be able to come to Ann Arbor, Michigan, and view the data in the physical data enclave.
But I'd just like to add that there is a lot of information available through ICPSR's website related to the data. So every variable included in the data sets is shown in a code book, and the code book includes like the sample size for that variable, what the label for the variable is, so it's more detailed than just the variable name, and also like the exact values of the variable. So if it's a dummy variable, like how many values are 0, how many values are 1. So you can kind of extract out the means, the mean, min, and max for the variables just from the codebook alone. So again, I just kind of highly encourage everyone who is interested in these data to get very familiar with the documentation memos that are on the website for each data file, as well as those codebooks, because they really can help give you something to think about before going through the application process.
Thanks, Ann. Another question we have is it possible to determine whether a family received home visits from multiple home visitors and how long they were engaged with home visiting in the restricted access data?
Yes, so we kind of touched on that, but for each family, you can tell which home visitor the family saw during the time in the study, as well as how many home visits were received and for how long. So that gets at the duration aspect of the experience.
Next question is, can researchers use MIHOPE and MIHOPE-Strong Start restricted access data at the same time?
I'll take that one as well. So you can use the 2 data files at the same time if you apply separately to access both MIHOPE and MIHOPE-Strong Start. You can't intermingle the data, so you can't, merge the data sets, but there's no limit to kind of applying for both of the data files and using them for your research.
And then we have a question. Since follow-ups are being conducted with MIHOPE study participants after the focal child is 15 months of age, will these data be added to the archive data at ICPSR?
I can take that one. So we do have plans to add to the MIHOPE archive data over time. Currently, we are working on archiving data from the data collection when children were 2.5 and 3.5 years of age. We likely would archive data for kindergarten as well. So I think over time, as the data are ready to be archived, we will be posting updates, and those data will be linkable with those that have been archived to date.
Okay, great. Looks like those are all of our questions. So we just had one final slide, which was that our website is childandfamilydataarchive.org, as mentioned before. And if you have any questions or need any assistance with applying for restricted data or any questions that come up after this presentation, please email us at cfdata-help@umich.edu. And yeah, we want to just thank everyone for joining us today for the webinar, and just put in a reminder to sign up for our CF Data listserv to receive notifications on data release announcements, other data webinars, and workshops that we host. And you can sign up for our listserv on our website. And as mentioned, we will post the recording of this webinar to our video resources page within a few weeks. So yeah, thanks everyone for coming.
All right, I am going to end the recording now, if that sounds good to everybody. And then we will end the meeting.